you so much, Victor and Patrick and Jim and Sheila, Jillian, all of you made it so pleasant to be here. I feel very, very privileged to get a chance to make a few remarks to you, but also a bit frightened because everything important has been said. I have to fill some time, but I want to just acknowledge the quality of the conversations in this meeting have been astoundingly good. I think I want to zoom out for a minute and just point something out. The fact that this meeting can occur and this much sharing of thoughts about making the world better with people of such skill and intelligence as we've heard from has got to make you an optimist. The water level clearly is changing. This meeting could not have been held 10 years ago and maybe not even 5 years ago, so victory is in sight. It's going to be hard. There's a lot we need to do, but just take a moment and think about how much intelligence and wisdom and goodwill has been shared here from people that are struggling with some pretty hard problems. So I feel very optimistic. With this much attention, things have got to change. That said, I'm very opinionated. I've got some ideas about how we have to approach this. Some of it will resonate with what I heard in the time I was here. I remember I came late because Boston was not moving. So I may have missed some of the important messages early on, but I caught quite a bit was going on, and some I agree with and some I don't. I'm not going to be gentle about what I think would help in the proper direction, and I don't mean to offend anyone with whom I will therefore respectfully disagree, although I agree with almost everything. I want to do two things. I've got to share two stage setting slides. These don't fit into the flow of my talk, but my talk's going to be two stage setters, just things to park in the back of your mind. This is speaking to your unconscious. Then I'm going to talk a little bit about the background, what I think is the context of the work we're trying to do, and try to give it a little bit more punch so you can see where we are, and then I'm going to make three recommendations for steps to move ahead. Any of this can be wrong. Nobody, me least of them, can be sure about the next directions. We're going to have to discover this together. But two context settings. This one just kept occurring to me all the time. I was mentioning it at dinner last night to Pierre. I was shown this by Jean Hartley, a professor at University of Warwick in the Open University in the UK. She's a sociologist. She was quoting someone. I can't give the pedigree, but maybe in the notes of this meeting we can track it down. We'd like to simplify the world. You'd really like to understand things. And the question that USAID has brought forward about what works and what doesn't is an attempt to gain mastery of a very complex terrain, which is a good thing to do. In the answers we seek, we'd like three properties. We'd like to be able to answer the question about the 6 models or about approaches to improvement. And and Jean says there's 3 properties we'd like. We'd like it to be simple so you could write it down and anyone could understand it. You'd like the rules or the conclusions we reach to be generalizable, so it doesn't matter whether I'm working in Africa or Latin America or any least low-income country. I can use it, and we'd like it to be locally useful, so I can take it home and put it to work locally. Here's the problem: you can't do this. In a complex terrain, there are no solutions. There are none that are simple, generalizable, and locally applicable. You can get 2, but not 3. If something is simple and highly generalizable, in a complex world, it's not going to be useful locally. You're going to have to adapt it, and that's going to not be in the terrain of the rules you've just got that are generalizable and simple. If something is generalizable and locally useful, it's not going to be simple because it's going to include all the dimensions of complexity that lie within the local setting. And if something is simple and works locally, it's going to be locally applicable but not generalizable. And we are stuck here. This is the epistemology of learning, trying to learn in a very complex terrain. What I'm saying is disrespectful in a way because it says the question we've been asked, which is which of these 6 models work, it's just there is no answer. Give it up. We're not going to have an answer. If we try to make an answer that's generalizable, it's not going to apply to local context and so on. So this is in the back of my mind, and it means that the pursuit of knowledge that we're now engaged in is going to have to be respectful of the enormous difficulties of learning in a very complex terrain and respectful of that. And I'll make that clearer in my further comments. The second thing I want to show you is where do I point this? Can you advance the slide for me there, Rachel? This is my grandson, and I always have to put a picture of I have 3 grandchildren. I'll be taking care of 2 of them this weekend here in D.C. This is Nathaniel. Nathaniel's sitting in his favorite place in the world right now, in my home, where he's living with his mother and father, just came back from Zimbabwe, on a heat register. That's the heating system, and it's cold in Boston, and he loves to sit there. Nathaniel is 5 years old. He will sit there for 2 hours at a time. If it's supper time, you have to call him 18 times to get him to come to the table. What he's doing is playing with Legos. You know what Legos are? He is a Lego fanatic, and he will just have at it and at it and at it. What he'll do sitting there on his favorite place is build the most complicated thing he possibly can build, and then take it apart and try again and build something even more complicated. Usually right now it's a spaceship. Nothing can stop him from improving. He's completely, thoroughly devoted to it. It produces in him a sense of joy and accomplishment. He can't wait to show you what he built. I'm going to come back to him at the end, but I want you to close your eyes, if you would, for a minute, and imagine a workforce around the world of millions of healthcare workers and people in clinics and organizing things, all of whom were Nathaniel when they were 5 years old. That latent motivation to really do well in the world, it's there, it's in abundance, in a very poor world, in an area where we really wish we had more. Believe me, the motivation to improve is out there. What we have the job, I think, in leadership is to try to release that motivation, to return people to the passion they once felt about perfecting whatever they're trying to do in a highly interdependent and complex setting. I warned you, that's background. We're going to come back to it at the end. So now some thoughts about where we are. I think I have like 5 or 6. There's some are conclusions from what you said, some are stuff prejudices I bring in. The first is, we need to be honest, I think, with ourselves that in general, what's being done now in the world of policy and framing to support improvement in complex healthcare systems is quite pervasive. I think it's costly, and I think it's unscientific. That is, the general approach to making healthcare better right now out there is not tremendously centered on strong theory and practice. That's the honest truth. It's founded on inspection. Just like in most of the rest of public policy, the attempt to make healthcare better still rests on a foundation that says you inspect the work and tell it to get better. We used to say, and a miracle happens. I'm always reminded of the African proverb I learned when I was working in Ghana, that weighing a pig does not make a pig fatter. The general approach to improvement in far too many policy contexts is simply to go weigh pigs and expect something to happen. Further, the particular approaches that we see out there too often are demoralizing of the Nathaniels of the world. There's something about the way they approach the workforce that takes energy and pride and imagination away from the workforce. And I see it too much in this country and abroad. It's not true just of low and middle income countries. It's true around the world. That's what in my career, I'm struggling to change. I'd like us to have an approach that's more founded on something we might expect to work. The second, given the most punch in this meeting by Jishnu, is that quality defects are pervasive. I want your slides. I think that we do have a problem. I remember meeting, Patrick may remember, we had a meeting here at the IOM years ago at which fellow Rampele was there. It was how many years ago? 8, 9 years ago. And we were talking about this problem, and I remember something she said, it's always stuck with me. She said, we just need to keep in mind that it is the poor people of the world who can least afford poor quality, trying to return us to the center, and that we really have to do this if we care about justice and equity on the planet. Quality matters, and quality is not where it needs to be. We need to understand that. Third is the rule that Pierre showed you in his opening theoretical comments. These qualities we seek are properties of systems. And that deep understanding that systems produce performance it's the heart of the Chasm Report, it's the heart of any modern manufacturing or service company or industry in the world knows that it has to get quality by change of systems. There's no other approach is going to be effective. And the systems working in have particular properties. In general, they're highly interdependent, nonlinear, complex human systems. They're not like a thing like a pill. They're very complex. And it is those nonlinear, complex enterprises whose design and conduct produces the performance we're after. The fourth observation is we are not the first in this terrain. We're not the first industry to try to improve in complex nonlinear human systems. In fact, the field of improvement has a pedigree. It goes back to at least 1920 or 1926. The work of Walter Shewhart was sort of a historic turning point. It had nothing to do with healthcare. It was done in manufacturing. But let us not be arrogant and assume that we in healthcare somehow discovered the problem of improvement in complexity and are the first to be grappling it. We are not. And I think one of the things that will serve us well in global health will be to ask outside healthcare who has worked on improvement in very complex terrains and have the humility to say they know things we don't. That's informed my work for 30 years now, and I want to make that clear. You may think you're the first, but you're not. The fifth comment I want to make is about evaluation. And here's where I may be alone in the room. I think evaluation is one of the most toxic enterprises in the planet with respect to actually accelerating improvement in healthcare. The reason is the epistemologic framework, the action framework for, the learning framework for evaluation as classically carried out impedes change. The reasons would take an hour lecture, not 10 minutes more that I have, but some of them are: first, evaluation as currently practiced has cycle times that are far too long for help to people that are dealing with the day-to-day burden of trying to make things better. We think we have the privilege to lay out a 2 or 3 year evaluation cycle for people that have something's happening next Tuesday, they need the help. The second is evaluation is generally practiced is just not sensitive to the local context. On that triangle of generalizability, simplicity, and local adaptability, we have favored generalizability and simplicity instead of deep understanding of local contexts. That's how you get tenure. And it doesn't work. It doesn't help the local context. It impedes them, in fact, because you come up with rules that they can't use, or that if you insist they use, actually stand in their way. Generally, evaluation frameworks that are widely used ignore context and mechanism. If you've read the work of Ray Pawson and Nick Tilley on realistic evaluation, you begin to see an epistemology very, very sensitive to local contextual factors and local details of mechanism. And until we have an evaluation framework that can take context deeply into account, instead of seeking this enormous generalizability, we're just going to produce rules that people can't use. And probably the worst aspect of evaluation of the type I'm talking about is it's dismissive of local knowledge. Think about an RCT, a randomized controlled trial. Its purpose is to blind us to locally specific changes. That is part of the design. We call them confounding factors. What an RCT, or classic evaluation, calls a confounder is local knowledge. And if you think about how you learn in the rest of your life, in your marriage, or in your cooking, or in your tennis game, you want every piece of local information, every swing of the racket, every gram of saffron, every word you say to your loved one is an experiment. It's a learning in context, and that is how improvement occurs, because the only care that really matters is the care that happens at the sharp end. And so I think we need seriously to take this issue of evaluation and its approach. Indeed, the very question this meeting was called to ask, which is which of the 6 things work, is not, that comes from the wrong epistemology. I'll tell you what, they all work sometimes, under some conditions. And our job isn't to run a derby, a horse race, to figure out if number 1 is better than number 4, is to understand what are the things about number 1 that make it work sometimes and other times not, and the same about number 4, and continue to put together the next meal and the next meal and the next meal, not to take a linear view of comparison. I must say it is my very strong opinion that in general, randomized controlled trials are a highly impoverished technique for learning what we need to learn now to help the rest of the world. There are very good ways to learn, and a lot of you use the term rigor in your, we need rigorous evaluation. Absolutely, I am a rigor person. But the rigor behind modern methods for understanding from local context, it is there. Measurement over time, run charts, control charts, time series. Case studies, as several of you have been talking about, can be done in highly disciplined ways using appropriate ethnographic and anthropologic techniques. I think it was Jim Hybe who used the term program knowledge. I hadn't heard that term before, but he's talking there about this idea of capturing local knowledge and respecting it. So I'm for evaluation, different evaluation, an approach that's going to be far more sensitive to the details that really matter when people are trying to do good work out there, when every Nathaniel at work is trying to make a better spaceship. The last comment is about that, which is this is everywhere. This idea that the healthcare workforce, by which I mean everybody in management and right down to the front line, is a learner, can be a learner. That what they see and how they learn and what they found out is very useful information potentially for everybody else, is at the heart of proper leadership and management of improvement. And that infinite respect for the knowledge of the sharp end, the cold face, is, I think, one of the really great bright lights in the future of the kind of stuff we can learn. And this is there in abundance. Almost every single person at work can help us understand something we didn't understand before. So that's stuff for the background. Let me take a few minutes and talk back to theory. I'm sort of going back to what Pierre, I think, started with this yesterday when I wasn't here, because I want to run by some theory with you. I'm simply not able to make this change. There we go. Now, this is the elevator speech about improvement, okay? We want to make things better. What does it take to make something better? Two things. If you're going to get better at something, you have to have an aim. You have to know what you want to improve. You could be an individual or it could be a community. I recently decided I'd like to learn Spanish. Even at my age, I think it's possible. I will never learn Spanish unless I decide to. You're not going to get better at knitting unless you decide to. You see, aim is essential, and then you have to have a way to pursue it. And I want to talk about aims for a minute, because I think there is a possibility for us to take the aim issue forward, as Victor was just talking about, and make it the flagship of the next step in this enterprise. And I'll make that case in a few minutes. That said, the second part is method, once you know what you want to accomplish. And earlier in my comments, I made this statement that we are working in a relatively uninformed, unscientific approach to improvement generally, globally. This is not working. Am I doing something wrong, or can I? Okay, great. So you all know that, because I wrote this in a paper years ago, others have written the same. The hegemonic approach to making things better has very little to do with what we've been talking about on these 2 days. It is, next slide, it's called reliance on inspection to improve. You get all the metrics. Everyone here wants measurements, so do I. You get all the measurements, you get the array of performance in the population, all the hospitals in Kenya, all the surgeons in Nicaragua, all the whatever. You draw the distribution, and then you think that improvement is culling. Improvement is the finding of the exceptionally bad, and then you do something to them. You retrain them, you correct them, you shoot them, whatever. You get rid of them. And that concept of studying the population performance and removing the ones you don't want is culling, selection, and it is quality management in industry in 1920. It's how Henry Ford kept the quality of Model Ts where they are. The whole world of production has moved beyond reliance on inspection and improvement a half a century ago. Healthcare never did. It stayed stuck for the most part in an agenda of getting all the data you can, studying the population, and finding what to intervene on. And what that does, next slide, it shuts down Nathaniel. The inspected entities, the workforce, the hospital, the surgeons, the clinics, they hate it. They hate it. They're trying hard every day to do their best. In comes the inspector to decide if they're okay or not, and it just produces fear. And all of this is called the cycle of fear that Bill Schirkenbach wrote about at the General Motors in 1960. The inspector comes. The inspector's hated, by the way. Quality improvement, quality assurance people don't get invited to parties. And what happens then, of course, is the workforce gets control of the information that could be used to hurt them. You could call it lying. I'd call it rational behavior, because they're trying hard to do this stuff, and here's the inspector just hassling them, and all they want to do is make them go away, which you would do too in that circumstance. And then that micromanagement gets managed right into the entity, and all this cycle of decay falls, and they stop working with the Legos. Why would they take a risk of taking apart the spaceship and building a new one if it could be wrong? And so innovation, search, aspiration decays in the face of its reliance on inspection for improvement. Now, everyone in the room knows what I just said. If you've been studying quality in the past decade or 15 years, you know there's a better way. Next slide. The better way is learning. It's continual improvement of what's going on in the population. The nice thing about this is everybody's in. We're no longer finding a few that aren't doing well. We all get to think. We all get to pool our Legos and work together on making something better. And the trick is, how can you set up a system of leadership, policy right down to the front line, that fosters this kind of continual learning? That's what improvement is about. The systems view, the next slide, is key. That if you really want to shift to that continual improvement mode, you're going to get very, very interested in the design of what's going on. You're going to see how highly active retroviral therapy is being managed in a complex way for a population of people in KwaZulu-Natal. As a system, you're going to try to understand, thank you, all the dynamics of a system. I don't have time to get into what a system means, but if we're going to be improvers in the world, we're going to be systems thinkers. We're going to have to think about these interdependencies as core to performance. Now, the problem is that does not happen naturally. Because reliance on inspection is so pervasive, because systems are opaque, because we don't have the data, because management is naive, we're in a very toxic culture in general around the pursuit of that continual improvement. But we know what it looks like. We do understand in general, remember generalizable stuff is risky, but we're going to generalize. You need to set in place a context that gives the workforce the tools and knowledge to act and the support to do it. And I've always said it's three things, and we've all talked about these. In fact, these identical words have come up repeatedly in this past 2 days. You better have a technical approach to changing a system. So I can wave my hands about system change, but what do I mean change a system? I mean, I'm going to try something new and see if it works. I think it was, one of you, was it Nashiket said PDSA is obvious. Plan, Do, Study, Act is obvious. It's what Nathaniel does when he's building his better spaceship. He has a little piece. He doesn't know where it goes. He sees if it fits. If it fits, he uses it. If it doesn't fit, he tries again. Plan, Do, Study, Act. When you're trying to find out if pharmacists can do complete care with highly active antiretrovirals in KwaZulu-Natal, that's what you're doing. You're trying stuff out and seeing if it works. That's the technical model, and you saw this in the earlier talk. The technical model is, there are many different forms of it. I am really cumbersome with this. This is the model for improvement I think Pierre showed you. It means, it's just a way to think about improvement. You get an aim, you find out if a change is improvement, you find someone that might be doing it better than you and copy it, and then you put it to work locally. It's a very simple way to think about it. It's not the Bible. There are a lot of ways to think about it. Every single modern model of improvement, whether it's Nathaniel learning to ride a bicycle, me working on a better marriage, or healthcare getting better in Nigeria, is going to involve testing. And so that's what I mean by technical model. The problem with the technical model is it's countercultural. Remember, in a system characterized by fear, people don't try things out. Why would they? You have to set in place some environment in which people will try things out, and learning can begin to be free to work. I think every single one of the 6 models we're looking at has elements in it that try to do that. They try to tell people, hey, it's okay to try something. If they work, they do. Now, I'm a fan of the collaborative model. It's not the only thing to do, but the collaborative model, the Breakthrough Series model, was set up in 1996 to set up an environment in which it became the norm to try things out. That's what I mean by culture, a culture in which learning is valued. And all of that has to be harnessed in strategy. Oh, one other thing before I get to strategy. This slide comes from the work of the Strategic Framework Board of the National Quality Forum back in the year 2002 or so. It's a paper that I wrote with Brent James and others, and it points out something that's very relevant to the next steps for USAID. Everything's about aim and purpose. We can't not going to improve unless we decide to improve. And we will have to know how we're doing. That's canonical. You're really unlikely I can get better at golf if I don't know where the golf ball goes. I can't get better at an apple pie if I don't taste the pie. You better have a way to know how it's going. So measurement, the kind of thing Sheila Leatherman has been just leading the world on, is absolutely essential for learning. The problem is measurement can feed one of two pathways. Pathway one is that reliance on inspection. I use those metrics to find the bad guys and get rid of them. And all that cycle of fear stuff happens when I'm culling. I will point out, in a politically managed system, an accountable system, there will be some of this. You can't have thieves out there. You have to catch them. But the point is, exactly those same metrics are just what you need to get to learn. This loop of learning, knowledge about the process, change in organizations and delivery systems, and then recursive learning is the learning cycle. But the key here is the same metrics are used. And when the psychology in the world is one of selection and censure, you've made measurement toxic, even though it's absolutely necessary. So I regard the journey of improvement as partly the restoration of trust and confidence in measures as our friend. And then the third piece is leadership. It's strategy. All of this is going to be led. You can't have the techniques being learned and used. You can't have the system safe for building a new spaceship unless there's a strategic intent. And that generally is going to be led from some executive level, policy level, management level. Here, Joe Duran's trilogy is not a bad way to think, I believe. What, as a leader of a department or an agency or a corporation or a nation or a family, I'd like three things to go on. And they go on all the time. And if you're going to inspect my ability to lead, you better find that I can stabilize things if I need to. It's got to be a safe place. If there are going to be fires, we've got to have fire extinguishers. Nathaniel, I don't want Nathaniel to run in the street. I'm going to be really careful to keep him from running into the street. This is quality control. This is what you've called assurance or accreditation. It's just the basics. And some of you pointed out in resource-poor settings, it's very crucial that you actually get that control in place. So what's stable it needs to be stable. The second is continual reinvention. It's quality improvement. Stability isn't improvement. Stability is just safety. Beyond that is the journey of continual knowledge growth. The third piece, Duran called quality planning. It's innovation. It's design. We're now, I think, in a majestic moment in healthcare design in developed countries, I think, if I can overstate it, moving toward the concept that the person doesn't have to come to the care goes to the person. We're going to substitute telemedicine, remote care, just like everything else in my 20-something kids' lives. We're going to move into a virtual care system. That isn't improvement. That's complete renovation. That's tearing the thing apart and doing it all over again. And a complete quality strategy has in it control, improvement, and planning. To me, those are the essentials of where we need to understand where we're going. And this Derby idea, this competition that says, is accreditation better than collaboration? Is that better? They're all useful. And I think what Pierre offered you early on is a kind of consensus building idea. We need some forms of control. We need some forms of continual learning. And we, by the way, need to preserve energy for continual serious reinvention, and that's what a complete quality strategy looks like. So that's where I'm coming from. I'll stop being a wonk now and try to go into what I think we ought to do. I have three suggestions, and I think they're probably, at least two of them are wrong, but I don't know which two, so you be the judge. I think we have to go back to will. I don't think we're going to do very well with mechanisms of improvement without a reassertion of the absolute urgency, need, and dimensions of improvement. Why do I think that? I think that because of what happened in the United States in 2001 with the Chasm Report, just like Victor said. That was preceded in 1999 by two errors human, the safety report. I will tell you, those two reports turned a corner for the United States. We're nowhere near done. We're 5% of the way there. But it was zero until the National Academies of Sciences, with its gravitas, came forward and said, it is now time to recognize the level of defect in care. It named the defects and set out a theoretic framework the general theoretic framework for tackling those defects. Today, every hospital in America, I would say, or 4,000 of the 5,000 have safety, effectiveness, patient-centeredness, timeliness, efficiency, equity mapped into their strategy. You can go there and see it. Some are making progress, some aren't, but it really changed mentality. I do not believe we have this globally at all. Some countries have. There's a little. Scotland's doing a good job. Denmark is on its way, but there's Singapore. But we're not seeing it globally, and not in the low and middle income countries. And I think it might be time to have quality chasm low and middle income countries. I would say that there's one problem with the chasm framework, which I'm going to show you, which would lead me to make a suggestion about a difference about the way we might be able to approach this. The chasm report provides a really neat framing that the graphic did not appear in the report, but it's behind our work. It said, every system is perfectly designed to achieve the results it gets. Quality defects are a systems issue. But there are 4 systems of relevance, and they interact. They're interconnected. System 1 is the experience of the patient, community, and family. It is the AIMS itself. Now, it's weird for you to hear me call AIMS a system, but they are. When we decide, AIMS convene a system. So the first part of the chain is to be really clear about what we need to improve, as experienced by the people we're trying to help. The second part of the analysis was, what needs to change about the processes that the people who need the help encounter, the microsystems? What are the design characteristics of microsystems with lower defect rates? The third is, what has to change about the organizations that house those microsystems? And the fourth is, what has to change about the environmental context, payment, professional training, regulation, and so on, that affect the organizations? That's the chain of effect. And I think one of the really important concepts behind the chasm report in 2001 was this is connected. They're interconnected. You can't, it's silly to work on policy without understanding what you want to have happen in microsystems. It's silly to redesign organizations without respect to aims. You have to understand the interconnections. And I think this remains a powerful comment there. If you therefore read the chasm report, you'll find in it aims. You'll find it design rules for the microsystems, design concepts for organizational support, and design concepts for the regulatory and financing scheme. That's the nature of that report. I'd love to see this emerge for low and middle income countries. Now, one change has to occur. The chasm report was written about care in healthcare. It's the experience of care. That's these 6 aims: safe, effective, patient-centered, timely, efficient, equitable care. That's about when you have your heart attack, when you break your arm, when you're depressed, when you need your checkup in your doctor's office. It's all care-oriented. Now we know better. The triple aim emerged that came out of IHI, and I admit that. John Whittington and Tom Nolan invented it, but it said, no, we're not done. This is where the 6 aims apply in the experience of care. But there's 2 other aims, and this certainly applies in low and middle income countries: work on population health at the same time, the generators of the need for care, nutrition, exercise, injustice and inequality, poverty, environmental threats. And they say that's health care too. And third is reduce health care's confiscation of resources needed for other purposes, so reduce per capita cost. And that's the triple aim. We didn't have the triple aim in 2001. That's 2005. And I would argue that if we were going to do this again in the US, or certainly if we're going to tackle a chartering document for low and middle income countries, it better range this far. Not just care, health, and per capita cost. I think that would be a great next step, and I would predict that with gravitas, a well-considered statement about the nature and urgency of the gaps that exist in performance in all 3 elements of the triple aim, I think it would be helpful. 2 other suggestions, then I'll shut up. Back to my somewhat sourpuss comments about evaluation, we're not stuck. We can get out of this. But I think we need a serious reconsideration of the epistemology of evaluation and improvement itself. If we remain in the trialist mode, we're just going to not make progress anything near we need to do. Can there be an epistemology of growth of knowledge in complex systems? Absolutely, yes. You know that from your personal life, because your souffle is better today than it ever was. We can do it in healthcare too, but we're going to have to start to have an epistemology, and I just wrote, top of my head, 5 rules of the proper epistemology. It needs to enhance intrinsic motivation, not quell it. It needs to accelerate the pace of improvement, therefore be faster, not slower. It needs to honor, respect, laud the knowledge of the front line instead of calling it a confounding factor and control for it. It needs to learn from successes and failures, as several of you have said. And I think a hallmark of the technical approach is that it will use measurement over time. The hallmark of the new epistemology is that you're going to see a ton of run charts and almost no p-values. It's going to be learning over time. Finally, and again, I will apologize for referencing my own work, but I wrote a paper years ago called A Learning World for the Global Fund. When the Global Fund began and Sir Richard Feacham took it over, he asked me for some thoughts about how to organize the Global Fund. So I wrote a paper, I think it was in Lancet. It was called A Learning World for the Global Fund. Nothing ever happened with it, but it laid out how to do that. How could you have a pathway to a learning environment, the learning pathway, not the assessment pathway. And I began to try to think through what the elements would look like. And I think the elements are networks of learning. It's de-siloing, as several of the speakers have spoken about. So we actually have structures of learning that are interconnected. I think there should be fellowship. I think it is, I don't want improvement specialists, but I'd like improvement fellows, people who know that wherever they're working, they're part of a global system of knowledge gaining, so locally they can represent the gaining of knowledge. And I think there's a role for some kind of international learning center. I think the observatory in OECD, and the EU observatory, I mean, is a sort of an example of that, but I believe we could have institutional structures that we do not have right now in WHO, in UN structures, in the OECD, that actually are the place you go to learn, and I think that would be powerful. Well, that's more time and thought than you probably wanted, but I think I'll stop there, and thank you so much for the chance to share thoughts with you.
Thank you, Don. Would you entertain a few questions?
Sure.
I'd like to begin with one, because I think you have the best handle on some history. You began your talk by suggesting that we had to build will for improvement. Build will for improvement. And I understand back in the late 90s when the IOM was contemplating work in this area, that there wasn't a whole lot of will. In fact, I believe the patient safety study was largely funded with IOM endowment money because no, or very, very few external donors had any interest in funding that kind of work. And you know, I'm kind of wondering if you had suggestions on how to build will for improvement. Back then, you know, I guess a lot of folks were moved by the number of deaths in hospitals. And yesterday morning, Ashish Jha, you know, shared well-known but very, very sobering figures on the probability of non-helpful treatment, for example, being 45%. I mean, if I felt I was exposed to something like that, I would probably run the other way. Do you have any suggestions on how to build will for improvement?
I have no better suggestions than anyone at this table might have. It's a great question, I think, Patrick. If I reflect, you're absolutely right. The CASM report, I think it's the CASM report and the safety report, they were IOM funded and not asked for by any external party. It was just a sense it was time to pull it all together. A remarkable fact. It rarely happens. But I heard Jishnu's data today. I mean, I think the information could be assembled that puts in one place the pattern and explains what the chasm is between what people could have and what they do have. It's still true in developing countries, but I think it's largely even probably bigger in low middle income countries. The two pieces that happened in the U.S. With the CASM report were one, the assembly of the knowledge and data. You know, there were 6,000 studies, I think, studied for the CASM report, or 3,000. It was a large number. But the second was the source. You had the National Academy of Sciences speaking out, a conservative body not used to ringing alarms, not expected to say the first sentence of that report is between the care we have and the care we should have lies not just a gap, but a chasm from a conservative science-based, the conservative science-based organization in the nation. So the source matters, and thinking hard about whose voice might be heard as not the usual suspects, but they're really saying it would probably be helpful. I'll say also, I think if I were to do that again, we might have assembled a coalition in advance that would then immediately take it under advisement, and I think there might be a way to think about it with ministers of health. I mean, you would know the structures better than me, but it's a great question. I'm sure those are only some answers.
Thank you. Yes, sir? Could you come up and use one of the microphones so we can be sure to capture your comment or question?
The HIV/AIDS development has added many things, of course, but one important factor to the environment of this conversation, and that is putting global health on the global political agenda. I think that is what we should be looking at. Where in that global political agenda, whether it's the G9 or the G20, whatever it is, the Doha discussions, the fact is that it has the attention of that machinery, which presumably presents us with an opportunity to feed into that some kind of a constructive idea as to how to turn that to this agenda, to build on that attention. Right now, it's got a lot of attention to the security issue that all of that engages. But it's been on the agenda for the last 5 years at most of the presidential level international meetings. And that tells us that there's something there to work with.
Are the MDGs a model for this? I mean, certainly you saw a lot of mobilization. Something happened that got people to pay attention.
Right. Anyone else want? Yes.
Sorry, just one quick question, because we've been having this big discussion in econ also about kind of research and things. And I completely agree with you that local context and locally generated knowledge is important, but I wonder whether you want to put a constraint on that. And the constraint is, how much is it going to cost? Now, the problem has been, so for example, I was part of a team setting up health insurance in India in 2007. And we needed a lot of research done on how to, get the system moving. And I went to like 60 different researchers saying, look, I have electronic claims data coming in. It needs work. Can you guys help me with this? Not one person said it was interesting. This was a system that within 5 years, we had 100 million people insured under it. I didn't find a single researcher who said they would like to analyze this data. They said, look, it's dirty data. It's going to take too much time. There's no publication thing here. Can you, if you buy out my time, I guess I can. So the bottom line is we actually have one person who can work on all of East Africa, 2 people who can work on, some other country. So one of the things we've been thinking about a lot at the bank is what happens with local specificity when you add on the constraint that there's no human capital to work on these issues. And that's where we've been coming down on the RCTs as well, which is, look, we understand that the RCTs don't give us the channels, don't give us an enormous amount of evidence on that. But the cost of doing the other stuff is just way too expensive. Relative to what, I don't know, because, perhaps we should try ignorance, but that's been the sticking point, which is when people say do this very detailed, locally specific stuff, it assumes there's no human capital constraint and no cost constraint. And when we put those two on, because we keep hearing USAID doesn't want to even fund research, how are they going to fund detailed time series data collection and people who will go into the context, spend a year there trying to figure out what's going on in country after country at this stage? And that's kind of where we've been stuck. So I'd love to get your opinions on that.
Well, first, I don't mean to be doing too much either or thinking. There certainly is a role for structured, centralized data collection and experimentation sometimes. My limited experience is a little different, which is that the context I'm talking about for use of local learning are essentially networks, local collaboratives. In Ghana, where we worked on under 5 mortality, Nana Chumdanso led that work. That was done with local collections in northern Ghana and in the east and west provinces in the north, with local groups that got together, 20 or 30 clinics that were trying to work on under 5 mortality, convening and saying, what are you trying? What am I trying? With the observers. There were people there to harvest the knowledge, but the learning processes can be quite distributed and very powerful when that happens. So it's not like, if you think the job is, stuff is happening up there, some third party has to collect it and then send it back out to everybody else, that's going to be very expensive. But when you set up a learning system in which exchange is happening locally, I think you can get accelerated change at very, very low cost. Indeed, I'd say it's so much fun that you actually add energy to the system, and then you can harvest from that. But I'm not sure about that answer.
So I'm curious about your thoughts on how you implement quality when you went from, say, a situation like IHI, when it was much more a cultural phenomena of going in for change and much more the models that came from manufacturing and so forth, to when you were in the position of being a payer, when your instruments and your tools were entirely different. And of course, a lot of disagreement on whether things related to pay for performance really work, whether you end up incentivizing a lot of people who would have achieved quality anyway. What worked when you moved into the payer mode from what you had known from the previous experience as someone who actually implemented programs? And what might the large UHC, universal health coverage programs, which are essentially programs for paying for healthcare, learn from what you might have learned from that transition?
That's probably a longer conversation than we would want to do right now. I'm happy to talk with you, but what I did at CMS was a couple things. One is I focused internally first, and my attitude, we had 5,500 people working. They distributed $820 billion to the healthcare system. And on day 3, I had an all-hands meeting, all 5,500 people virtually, and I laid out our new mission statement. I said we'd be a major force and a trustworthy partner for the continual improvement of health and healthcare for all Americans. I wrote that, and I sold my top table, read it and I said, we're going to organize that way. I said the triple aim would become our own internal metric. It's the achievement of better care, better health, and lower costs for everyone. And then I laid out the value structure to manage. I said there were 5 values that I said from then on, any lever I had, senior staff reviews, public reporting, would center on five values. Boundarylessness, we're going to work together across boundaries inside the agency. Speed and agility, unconditional teamwork, innovation, and customer focus. My brief was, I said, that's what we want healthcare to do, so we as the payer and supporter, because we had data and other things besides payment, we're going to do everything to ourselves, among ourselves, that we would want healthcare to do to their clients, because then we're going to be in sync. Each of those features, boundarylessness, speed and agility, unconditional teamwork, innovation, and customer focus, was represented in operational changes within the agency, new forms. Customer focus was key, and I began a series in which we brought in the people we're supposed to help, the doctors, the nurses, the hospitals, patient representatives. We had public meetings. The third lecture I became the trainer. I did 4 90-minute lectures to all 5,000 people on quality approaches, began a training program for 200 black belts internally. These would be people that could lead process improvements, personally reviewed their programs, but I also brought in people from outside to teach us their point of view. And the third lecture of the 4 was given by Sorrel King, whose daughter, Josie King, was killed by a medical error. One of my strategic imperatives was patient safety. So I had the mother of a child who'd been killed in a hospital lecture 5,000 people about what that meant to her and what she needed from the agency. So this customer voice, for example, was something I really insisted on. I asked for us to change our posture toward the healthcare system and begin to regard hospitals and doctors as partners, not the enemy. I visited every one of the 10 regions personally, first administrator to do that in 10 years. I was trying to act our way into the kind of behaviors we wanted. It took all three things I'm talking about: technique, the training of people to actually improve; culture, building the trust around the new values; and strategy organized around the aims. Our aims were triple aims. There were actually 19 goals that we set out for the time I was there, and I monitored each of them. I was trying to act, that's what I was doing. What I found was it was like any corporation I'd ever been in or studied. The public sector can act in a corporate mode in the best possible sense with people thinking in terms of process. Out in the greater world as a payer, we could then, with some credibility, begin to talk about patient safety and cycle time reduction and cost reduction, because we were doing it ourselves. And I felt as a payer, the key, we had carrot and stick leverage. You get punished if you have too many whatevers. But I was a little worried about all that stuff. But what we did do is set up networks of support. We launched the Partnership for Patients, a $1 billion investment in patient safety that invited every American hospital to get into the act of reducing hospital-acquired conditions and readmissions. And then I set up a support system, a network system nationally for learning. I couldn't stay there that long. I was there 17 months, but I could see the possibility. And I think payers can be very, very, very helpful to the learning world.
Maybe I don't need my mic. Don, I understand your issues with evaluation and its demotivating side effects. But in this meeting, we've had a number of discussions specifically with the challenge of establishing quality improvement as an integral part of healthcare in lower and middle income countries, as an area with many challenges, not a well-established area in which we have all the answers. We have a lot of questions. And repeatedly in this meeting, the issues of the approaches of research and evaluation have been raised as the way to improve our approach to this new field, that is quality improvement in these countries. I would just like to first verify that you think that evaluation and perhaps research is not the way to go, but if that's not true, let's straighten that out. But if it is, what are the alternatives for refining our approaches to quality improvement in these new settings?
My view is that classical evaluation approaches, experimentalist approaches, are going to be very hamstrung in trying to learn how to learn the way we need to. But that's not about value. That's not anti-evaluation. It's anti-one. It's questioning the tactics of evaluation. I personally think methods of learning in real time, operational research methods, tracking over time, ethnographic methods, anthropology and ethnographic studies, discipline case studies, can be full of information. And in fact, any modern improvement endeavor includes a ton of very rapid cycle evaluation ongoing. Selling that to OMB or external parties is very hard because they're in the old mode. But I'm for a different modernized approach to evaluation, not against it.
And Bill.
Don, the 3 points you made about the way forward is as good a model as I've heard. So how do we get started? Who's going to lead this? Nathaniel doesn't buy his own Legos and get fed so we can be, and this is not going to happen spontaneously, or it already would have. And so who should we be lobbying to do this? Should it be, there's IOM, WHO, USAID, or should there be a global IHI or something that with a charismatic leader can make it happen? What's the next step? Because I think you make a compelling case for it, but we're going to leave here and get on a bus and a train and stuff like that, and then what? How do we carry it forward?
I'm not sure, Bill. I think it probably should be done by organizations that already have a lot of gravitas. you've listed World Bank, WHO, UN, this academy, other academies. I think the plea for this approach to really accelerating improvement will have much more chance of success if it comes from classical entities that are now saying this is what to do. But I don't know the architecture of the leadership in the global health scene enough to be clear about the answer. I would trust you with an answer. I mean, who would you believe? Who would you mobilize?
Very good. Alex can have the final question.
Yeah, thanks. This touches on a little bit some of your comments on evaluation and I guess the limitations of, let's say, RCTs or the classic experimentalist approach, as well, Bill, as your question about how to move forward. I mean, I'm sorry if I'm just being small-minded, but I think high-quality data will help enormously. And I completely appreciate your comments about local learning and the qualitative side of studying these kinds of systems. I think that's all completely relevant. But if in the end, this is a formula, this is an approach that can work at large scale, why wouldn't a classical RCT not show that? I'm not saying the other stuff shouldn't be done, but to me, and maybe this is partly a cultural thing, but I think that if you had that large scale, well done study in the language that a lot of people I think really would appreciate, that to me, I think that kind of evidence would be part of the way forward. Just put that out there. Thank you.
It's certainly merits much more exploration, Alex, but the problem is this that you're studying. Like if we said, let's do a large-scale RCT on parenting, you'd say, I don't understand what you mean. It's a very complex enterprise. Lots of people are doing different things. How would I know that in this case, we're going to pick this approach and this one as if there were two pills, a blue one and a red one? The interventions are far more complicated and contextual to permit of an RCT design.
Just to press the point, you've just articulated, an approach that my understanding is that this is a generalized approach that can work. It obviously needs to be kind of customized, and a lot of very specific things happen depending on, what problem you're trying to solve and where you're trying to solve it. But the idea is that if this is a model that could work in healthcare and has already been tested in the commercial sector, it's been around for decades, it can't be that hard to show that it works. I mean, pick your problem, as long as it's got relevance to global public health, and show that it works. Why not? Show how much it costs, do the qualitative work to help tell the story of how it worked. I think that would be enormously powerful if it's as great as, the advocates say it is. Sorry for being skeptical. I just trying to help.
If you could show me a design that actually does that, I'd be thrilled. But you say you want to do a randomized trial on what? The hypothesis is we could take X entities and have them rely on inspection, and X entities try to get learning going, and we'll do an RCT on that. I wouldn't have a clue as to how to design that.
The null hypothesis would be that all the stuff that you said doesn't work.
Dinner.
Clearly, there's room for a lot more conversation here, a lot more dinners. Well, we've come to the end of our two-day workshop. I just wanted to close by thanking a few people. Our planning committee, chaired by Sheila Leatherman. She's been a great friend of the Board on Global Health for a long time and did a superb job leading the planning committee. Others in the room who are on the planning committee include Ramanan, as I understand. No, am I wrong? You're just so present all the time, Ramanan, that I think you're part of everything here. Well, the standing committee that we respond to, Nachikut, I think you were part of this? In the standing committee? Margaret? Oh, I'm sorry. I was confused. I'm getting my lists mixed up. Well, the standing committee supports our planning committees. They're very coordinated, and we're appreciative of the efforts of both of them. I wanted to, though, just ask for a round of applause for Don. He weathered a terrible storm to get his way down here, and we thank you for that and for the words of wisdom that not only have enlightened us, but will also motivate us, give us the will to move forward. I wanted to thank Jim Hybe and his colleagues at USAID for sponsoring the work of the Standing Committee, and specifically the work of this workshop. Jillian and her staff, especially Rachel Pitluck, worked as a wonderful team, and I really appreciate their tremendous dedication. As you know, the workshop was webcast live, and so I want to thank not only those in the room who participated, but also those who participated via the webcast. I believe the webcast is going to be archived and posted on our website probably within a couple of weeks. Within YouTube and then on our website within a week or so. So if some of the information came a little too fast or you want to hear it over again, it's available in that format. And there will also be a workshop summary that comes out. Do you have an estimate for that, Jillian? It probably maybe 4 to 7 months, somewhere in that range. Yeah. It's a wide range. So you can be on the lookout for that. In the meantime, the Standing Committee will be re-engaged and discuss what's transpired, and hopefully we can come up with a timeline for moving forward on a larger initiative. And if those of you want to be part of that in any way, Jillian would be happy to receive expressions of your interest. Travel safely wherever you're going from here, whether it's down the street or around the world, and we look forward to seeing you again the next time. Thank you.